evening. On behalf of the Camellia Rose chapter of the Links Incorporated, I would like to welcome you to the webinar this evening. We have outstanding panelists that will share a wealth of information, education on preventive strategies, and resources about colorectal cancer. Our dynamic moderator this evening is Sarita Cathcart McLaurin. Sarita is a graduate of UNC Chapel Hill, where she received her BS in nursing. She received her master's in nursing at Emory University. After working as a clinical nurse specialist at Grady Memorial Hospital, she returned to Emory and attended the Post-Master's Nurse Practitioner Certification Program. She is a licensed nurse practitioner. She's been employed at Morehouse School of Medicine for over 25 years. She's an instructor in the Department of Medicine. Sarita describes herself as humble, a servant, and goal outcome oriented person. She's a charter member of the Camellia Rose chapter of the Links Incorporated. Welcome, Sarita.
Thank you, Dr. Johnson. I would like to introduce our first panelist. Our first panelist is Dr. Gary Richter. Dr. Richter is a native of Newark, New Jersey. He's a graduate of an HBCU, Howard University, in 1971. He attended the University of Pennsylvania School of Medicine, receiving his MD in 1975. Dr. Richter attended Emory University for his residency in internal medicine, where he served as the chief resident during 1978 to 1979. He completed his fellowship in gastroenterology at the University of Pennsylvania Hospital in 1981. During his final year of fellowship, he was a nutritional support fellow at the Veterans Administration Hospital. This experience has added to the way Dr. Richter manages and integrates nutrition with his patients, which makes a significant difference in their recovery. As we know, many providers are not educated properly or sometimes omit nutrition as a part of their healthcare management. Dr. Richter received his MBA from Kennesaw State University in 1998. He is licensed in the state of Georgia and the United States Virgin Islands. He's a diplomat of the American Board of Internal Medicine. He's a diplomat also of the American Board of Internal Medicine subspecialty gastroenterology. Dr. Richter is founder of his private practice, Consultative Gastroenterology in Atlanta, Georgia, in 1981, which he established this practice upon finishing his fellowship. He has been in practice for 41 years, still expanding his partners and staying abreast of current trends. He has privileges at Emory Midtown Hospital, Piedmont Hospital, Atlanta Medical Center, and VG, which is a gastroenterology practice in St. Thomas, Virgin Islands. Dr. Richter has numerous appointments as chair positions. To mention only a few: Morehouse School of Medicine. He's the assistant professor of clinical medicine, Department of Community Medicine, and Family Medicine. He was on the Olympic Medical Support Group in 1996. He's a member of the Georgia State Medical Association, the Medical Association of Georgia, and has been the director of the board of the Medical Association of Georgia since 2005 to present. He has membership in several organizations, but again, I'll only mention a few: the Atlanta Medical Association, the 100 Black Men of Atlanta, the American College of Physicians, the National Medical Association, the American Gastroenterology Association, and the American College of Gastroenterology. Let me not forget, he's an active member of Omega Psi Phi fraternity. Dr. Richter is well published in areas of his expertise. Articles can be found in Practical Enterology, Gastroenterology, New York State Journal of Medicine, and printed in books by Lippercut Company. I now present you to Dr. Gary Richter.
Well, thank you so much, Sarita, and I'd like to thank the Links for allowing me to participate in this very important topic. We're talking about colorectal cancer screening, who should be screened, and what we should be looking for. If we look at colon cancer, it's the second leading cause of cancer deaths in the United States, and it's the third most common cancer diagnosed in colon in the United States. So that we do have an understanding that it's a very common uh, 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 condition, and it is also preventable. And that's what we're going to talk about: prevention of colorectal cancer. Uh, there are several ways that we can screen patients. We have to realize that all colon cancers begin as a polyp, which is a growth in the lining of the bowel. If you don't do anything about that, it has the potential of getting bigger and bigger and going on to a cancer. So most of the modalities that we use to evaluate patients that have no symptoms, but we want to prevent colon cancer, has been trying to interface at the stage where the patient has a polyp or a growth in the colon. Most of the studies that we use to screen patients can be classified in two different ways. One is a one step, and that's the colonoscopy. Now, this is the gold standard by which all other modalities are evaluated. And then the second is two-step modalities. And, and those are the stool testing. You can either do hemoccult, checking stool for blood, the FIT test. You can do stool DNA testing. You can do a CT colonoscopy. There is a pill being developed, which is not available yet, which can be used. And there is a blood test that is soon to be marketed that is available. The most important thing is just basically getting screened. So the question would be, who should be screened? When you look at colon cancer, the peak incidence of colon cancer used to be between 50 and 70. But what has been found out over the past 10 years is that colon cancer incidence has increased starting at the age of 45, and it's getting younger and younger. You know, I mean, we're seeing people in their 20s that are being diagnosed with colon cancer. Recently, the American Cancer Society identified that this was so important that they suggested that we change from 50 to 45. The American Society of Gastrointestinal Endoscopy, the American College, and the American Gastroenterology Association all have submitted changes in their approach to for patients that are average risk. So let's talk about how do we define who is average risk when you get screened. An average risk individual is a person that has no family history of colon cancer, personal history of colon polyps, or colon cancer, or family history of uterine or breast cancer, or a personal history of breast cancer or uterine cancer. Those patients that are high risk should be screened more frequently than those that are average risk. In my practice, I look at it from the standpoint of risk factors. Does the patient have a family history of colon cancer? If they have any symptoms? And I also look at their diets. There's been studies that have shown that people who, the World Health Organization has come out and said people who eat a lot of red meat and processed food are a higher risk for colon polyps or colon cancer. So that risk factors, ultra processed foods, including lunch meats, sausage, bacon, those particular foods are present additional risk for the development of colon polyps. So those patients you have to look at may have to be screened at an earlier age, especially if they have symptoms or if they have a family history. A person that's had a family history of colon cancer should be screened, and that person has a colon cancer less than 60, should be 10 years from the time of the diagnosis. So if you have a family member that is 45, you should be screened probably by the time you're 35. And people that have a family history of colon cancer that is over or at 60, they should be screened by the time they're 45 or 40. That's the most important step that you have to realize. So you have high risk individuals that you have to screen more frequently and at an earlier age. And that risk is their personal history or the family history. Now let's talk about prevention. So when I look at a patient that comes into my office, the first thing I look at is whether they want the colonoscopy, whether they're concerned about doing the colonoscopy, and if they are concerned, I offer them additional modalities, because the purpose here is that everybody should be screened, no matter what modality you use. So if a person comes in, they have no symptoms of colon cancer, and they have a colonoscopy, that's the first step. We undergo the colonoscopy, we look around their colon, we make sure that everything is okay. If they have a polyp, then you have the person come back within a total of about 3 years, because you need to make sure, because if you have a polyp or a family history of colon cancer, you have a higher risk of developing an additional polyp or colon cancer. So if you have a polyp, we follow those patients up in 3 years. If the person has a normal colonoscopy, we're going to follow that patient up in 5 to 10 years. The science is 5 to 7 years for a polyp. Most of the societies suggest that you follow up in 10 years. What I've done in my practice, if you look at people of color, I see the majority of my patients are going to be patients of color. I consider them high risk. We have the highest incidence. We have the highest mortality and morbidity. We have the highest interval development of colon polyps and colon cancer than any other group. So when a patient comes in, you'll oftentimes hear the doctor will say, well, your colonoscopy is fine. We'll follow you up in 10 years. There may not be any intervention or anything. The patient goes home, they feel like they're doing well. I have incorporated in my practice where I do a fit test every year. And that's basically the standard of care, because number one, I'm concerned about interval development of colon polyps or colon cancer. Sometimes the polyps can be flat. Sometimes the polyps are too big to remove. Then you have to have them surgically removed. That puts them at high risk. If they have the stool DNA, you still have to probably do the fit. You know, the stool DNA oftentimes will miss large polyps that are severely dysplastic, and the small polyps and the serrated polyps that have increased risk. So in between, my gold standard is you do the colonoscopy or whatever your modality is, if you do a stool DNA, and then you follow up the patient on an annual basis with a fit test. That's how you make certain that they don't develop an interval development of a polyp or a growth in the colon. I also have a conversation about their diet. One of the most important things that has come along, I think probably about 6 years ago, I was at a meeting in Colombia, at Columbia School of Medicine. And at that particular meeting, they talked about the microbiome and its relationship to diseases. Now, this is related to a lot of different diseases, but especially with colorectal cancer, okay? Alteration in your microbiome, what you eat, can express different diseases, but is a risk factor for colon cancer. So I talk about diet. For women, you should eat about 25 grams of fiber, men, 38 grams of fiber. You should reduce the amount of fat. Fat is a risk factor for colon cancer and colon polyps. and it definitely reduce the amount of red meat and ultra processed foods. Those are the important salient points that I think I stress to my patients. I also suggest exercise. As you get over 60, you may say, well, I don't need to really exercise. But sedentary lifestyle predisposes you to a lot of different illnesses, and cancer is one of them. And if the larger your abdomen is, the higher the risk of you developing a cancer, and especially colon cancer. So I always ask patients to continue to do some form of exercise, in which half of it, they're getting their heart rate up, and the other half, they're comfortable. They should do about 150 minutes per week. And these are the things that I try to stress to my patients to keep them healthy as we move forward. I mean, when you're having symptoms of colon cancer or colon polyps or things like that, like change in bowel habits, bleeding, narrowing of the stools, anemia, oftentimes you're making a diagnosis of cancer in those particular individuals. But I have to stress to you that a lot of times you don't have those symptoms. I recently had a patient come in. The patient was 44 years old, and the patient just had vague abdominal complaints. The primary doctor did a scan, and the patient had a cancer. Colonoscoped the patient, and the patient sure enough did have the cancer. So oftentimes colon cancer doesn't have any symptoms, but you don't want to do a procedure on somebody that is having symptoms, because you already now are looking for cancer. We're talking about screening patients, preventing colon cancer. So the point is you should be screened. What modality you use depends on what you feel comfortable with. It could be colonoscopy. That's the gold standard. It's the only one-step procedure. It could be stool DNA, FIT testing. We do less stool hemocults because FIT testing is a lot more sensitive. The other modalities are there, but we don't use them as much. CT colonoscopy is used, but to a lesser extent. So when do you stop? A lot of people ask, well, I'm 70, and I actually see people that have they've stopped by the time they're 70. The recommendation is that you stop at the age of 75, and at 75, you have a conversation with the patient. If the patient desires to have a colonoscopy and is healthy, and depending on whether they have, heart failure, diabetes, severe diabetes, you may proceed with another colonoscopy on that patient until they're 85. But it's individual. But each of the societies have suggested that 75 is the period of time that you stop and start thinking about whether it's too risky to do the procedure. Doing any procedure, especially colonoscopy. You can still do Cologuard. The problem is that if you get a positive Cologuard, you have to have a colonoscopy. It becomes a diagnostic procedure, and you're looking for a polyp. The other thing is with Cologuard, unfortunately, we see a lot of false positives. And so what do you do with those patients? You end up having to repeat the examinations on several occasions because you have to have some level of comfort that the patient doesn't have a polyp. And let me say that when you do a colonoscopy, you have to try to do as quality an exam as possible. I was in New York at the New York Society of Gastrointestinal Endoscopy about 20 years ago. There was a gentleman by the name of Jerry Way, and he was the first person that started talking about flat polyps. Sometimes polyps are not the typical polyps that we see, but they can be flat. Some of them are very difficult to see. And that is why you develop these, you have this high risk for interval polyps or cancers in patients. And so you have to be very careful. So when you go in, it used to be people were coming out as fast as they could. They do an exam in 2 to 3 minutes. They thought that was good. But when I left that meeting, it changed my whole perspective on how I proceed with doing an examination. Not only do I make sure I get to the cecum, and most people should be in the cecum at least 95% of the time, but I carefully come back slowly. You should be coming back within over a 6-minute period. That's the quality indicator. And most of the colonoscopies, they print that out for you. 6 minutes, and you look and you get a good look and a good view throughout the colon. So I hope I've kind of given an overview of screening, and I'll leave it to our moderator.
Thank you very much, Dr. Richter, for that detailed explanation. And I do have a few questions at the end. Thank you. Our next speaker is Casey Flowers. Casey obtained her MS degree in clinical nutrition at the University of Memphis. Casey's thesis requirements were completed at St. Jude's Children's Research Hospital and was published in the Journal of Nutrition in Clinical Practice. Initially, Casey utilized her clinical nutrition skills in the hospital inpatient ICU before shifting her focus to outpatient weight management and bariatrics. In Nashville, she worked as the program dietitian, where she assisted in the improvement of patient outcomes by developing and revamping support group programs and in the center's social media presence. Noticing a gap in diversity, Casey decided to focus on improving health equity in weight management and bariatrics and accepted a position at Morehouse Healthcare in Atlanta. Outside of the clinical setting, Casey teaches a plant-based nutrition curriculum in a community cooking class as well as weight management curriculum to dietetic, pharmacy, medical students, and residents at various universities and medical schools. As an active member of the Academy of Nutrition and Dietetics, she has assisted in the development of Weight Management Practice Group's resource page, written for Weight Matters magazine, and appeared in the local Memphis and Atlanta news. She currently sits on the Education Committee for the Georgia Medicine Society for Metabolic and Bariatric Surgery chapter. During her free time, Casey enjoys backcountry camping and kayaking. We now hear from Casey.
Thank you so much for that warm welcome. And I'm so happy to be here with everyone today. And thank yourself for being here today, for taking this great step for your health and get some good information in. I'm going to try to squeeze a lot of information into a short amount of time. But if you take away anything from today, no, it's never too late to get started. Each change that you make with your lifestyle factors greatly reduces your risk for colorectal cancer. But, getting started is definitely a lot easier said than done, especially with the plethora of diet misinformation out there that's just a click away. I don't know about y'all, but I definitely see plenty of new diets come out each week. It can be a little overwhelming to keep up with. So hopefully today I can give you an overview of the first steps to consider to making a healthier life. So lifestyle factors account for about half of all bowel cancer related cases. Another quarter cases are explained by genetics and family history, but lifestyle factors is something definitely you can tackle. So when you're looking into lifestyle factors, the World Cancer Research Fund has made clear recommendations that influence specifically bowel cancer risk, including diet nutrition, specifically fiber, and just like Dr. Richter said, red and processed meats, and physical activity and managing body weight. So I should have warned you before, but I'm definitely one of those presenters that like for folks to interact, so get your fingers ready to type. My first question for you is, please respond in the comment section. When it comes to managing your body weight, because that was an important factor, right? What is the first nutrient to let go? Carbohydrates, protein, and fats. Which one is usually the first one to go? I'm going to switch over to the comment section, see if I can see any responses. We got fat so far. Anything else? Okay. Well, fat again. So fats was okay, carbs. Fats was really important to let go in the 80s. That was like the huge thing then. And then the 90s and early 2000s hit, and all of a sudden, carbs became everyone's biggest enemy. So if you've heard of Atkins, paleo, keto, and low carbohydrate diets to manage diabetes, most often nowadays you'll see carbohydrates are made the bad guy. which is unfortunate because whole grains and fiber, the increased intake of those, were all linked to lowering your risk of type 2 diabetes, overweight and obesity, cancer, and cardiovascular diseases. So please, please, please don't cut out that important nutrient of carbohydrates. In fact, a meta-analysis of 25 studies showed that for every 10 grams of fiber that's in our diet, our risk of colon cancers decreased by 10%, which is kind of crazy. It never works out that it's that equal 10 and 10. But yes, every intake of 10 grams of fiber you have decreases your risk by 10%. So how does that happen? Well, fermentation of fiber from fresh fruits, vegetables, beans and legumes, whole grains, like oatmeals and whole grain breads, result in the production of short chain fatty acids that lower the pH in our colon. So not those very expensive alkaline waters, but actually your high fiber foods. A lower pH slows down the creation of cancer cells and decreases the production of toxic byproducts. So Dr. Richter was talking about how important our gut microbiome is. Well, our gut microbiome is bacteria. Bacteria are living and they need to eat. Their preferred food for good bacteria is that healthy fiber. And those good bacteria will help take away those toxic byproducts, improving your overall gut health. Fiber is also rich in antioxidants and trace minerals. The antioxidants are important fighters for oxidative stress, which is associated with the creation of cancer cells. Dietary fiber specifically, which is found in grains like oatmeal and brown rice, is also known as insoluble fiber, can speed up the transit time of food through the gut, increase the bulk in our stools, and reduce the risk of insulin resistance, all while making our gut health overall better. All great reasons to make sure half of our grains, each time we put them on our plate, are whole grains. So replace that white rice with brown rice and you're doing yourself that 10-gram fiber percent better, right? Now, on to the second question. I hope you guys are ready. I got props, all right? So let's take a look at this plate. So which color section here do you believe meat falls into? Is it the blue section, the red section, or the purple section? So waiting for your responses. Which category should meat fall into? It says purple, purple. Got any more responses? Well, whoever said purple, red. So whoever said purple and red are right. So it actually should just be the quarter size of your plate. Another way to measure it is your palm size portion. So as you heard from my introduction, I'm very much a Southern girl. I studied nutrition in Knoxville, Tennessee, then went right over to Memphis, so born and raised in Tennessee. And looking at my father and brother's plate, I would always see half their plate be meat. You know, their excuse is, I need protein, you know. And so after spending like over thousands of dollars on student loans, a very expensive I told you so, I got to redirect them to the most important factor of decreasing the risk for cancer, specifically colorectal cancer, is to eat less red meat and processed meat. So again, it should be either the red or purple section on your plate. I was very unpopular at Thanksgiving for a while, but it's okay. We're okay now. But it may seem obvious what red meat is, right? But some white meats actually count as red. So typically we think of cattle, lamb, pigs, and goats. Well, I didn't mean to say pigs, but those four-legged animals. Now, sometimes pork appears white when cooked, but it's actually red when raw due to its high hemoglobin content. So it is put in that red meat category. Chicken and fish are not linked to a higher risk of colon cancer. However, processed meats, that includes fish and poultry when they've undergone salting, curing, fermentation, additives, smoking to enhance flavors or to improve preservation. So like bacon, hot dogs, all your sausages, so even chicken sausage, ham, and salami all belong to this processed meat category. My way of thinking of it is if it can sit in your refrigerator for 7 days, because we all know raw meat only lasts in the fridge for about 3 days, 2 days, you know, before we got to throw it out. If it can last there longer than that, then it's most likely a processed meat, right? Unfortunately, I don't have time to break down the specifics of why those red meats are directly with colon cancers, I'll just give you a brief overview. So there's compounds like N-nitroso compounds that are produced in the gut by red meats that can cause increased risk of errors during the development of DNA. So when we have those errors, that's when we get those cancer producing cells. Also, the way you prepare meat. So when you grill meat, you notice that black on it, that's actually a cancer causing agent as well. Another general overview could be the high iron content of red meat can produce oxidative stress and damage the lining of your bowels. I don't know about you, but 1 or 2 times I've taken too much extra iron. It definitely hurt my stomach. Not to say that iron is it is a very important nutrient. If your doctor prescribes it, please take it because low iron has its own risk factors. But of course, you don't want too much iron in your diet. But this isn't a biochemistry class, right? This is just a general nutrition talk. So again, when it comes to portion your meat, you guys got this perfectly. I'm so proud of all of you. Aim for those lean meats, the portion size, your palm size. I know all my patients are tired of hearing me say the less legs, the better. Stay away from those 4-legged animals. Choose your chicken, turkey, fish. And then, of course, meat does not have to be included at every single meal. A lot of us are worried, if I don't get enough protein, then I won't meet my weight management goals. If I don't get my protein, then I'm at higher risk for protein malnutrition. Well, the good news is a lot of those high dietary fiber foods I listed before, like the beans and legumes, like the grains, like oatmeal, have protein in them. So not only are we getting that good protein, we're getting good fiber, we're getting good antioxidants. So it's a more balanced meal. And always, always, always make sure half your plate's that blue or half your plate's those non-starchy vegetables and fruits, of course. So Dr. Richter did talk about the importance of physical activity as well. I won't go too much into detail about it, just to say that 150 minutes a week, you deserve 150 minutes a week. That's 30 minutes, 5 days. That's 2.5 days of 60 minutes, 60 minutes, 2.5 times. That's walking down the street 15 minutes and walking back 15 minutes. You deserve that. It's going to lower your risk for cancer mortality. It's going to improve your insulin sensitivity, and you're going to feel great. It finally feels wonderful outside. So please go outside, get some vitamin D and some exercise in. And it wouldn't be me if I didn't bring up my personal pet peeve, because we did talk about weight management, but BMI. Has anybody been to the doctor and they wave BMI in your face and it hurt your feelings a little bit? Well, BMI can sometimes be biased to certain body types. So I don't like to look at as much as I like to look at your overall waist circumference. That's going to give me a better picture of your overall health. For men, it's recommended that their waist circumference be 40 inches or less. For women, that it's 35 inches or less. Now, why is waist circumference so important? Well, less waist circumference means less visceral fat. Visceral fat is called visceral fat because it's around all of our visceral or major organs. Visceral fat is also metabolically active, meaning it can directly change metabolism of certain hormones and inflammatory markers linked to insulin resistance and increased cancer risk. So if you feel your jeans getting a little tighter, definitely take out that measuring tape and see if your waist circumference is fitting in those more appropriate roles. So again, lots of information in a short amount of time. However, the takeaway, you don't have to be on some crazy restrictive diet to be healthy. You just have to focus on a balanced plate, reduce your intake of meat, and don't be afraid of those whole grain carbohydrates. And thank you again for being here. I will see you in the Q&A.
Thank you very much, Casey. Thank you. That was very, very informative. I would like now to introduce our last panelist. Our last panelist is Marshall Walker, a true survivor. Marshall Walker is happily married to Ralph Walker. They have 3 boys. Marshall is a graduate of Spelman College with a degree in human resources. She was employed by Hertz as an auditor account manager for 29 years prior to her diagnosis at age 42 with stage 3 colorectal cancer. Her sons at the time of her diagnosis were 5, 10, and 20. Marshall and Ralph lived a perfect, healthy, well-traveled, and exciting life with no illnesses diagnosis, no health issues prior to her diagnosis. After her journey with colorectal cancer, she did substitute teaching, then early retirement. She enjoys friends, traveling, living life, and taking care of her grandchildren. She is a 23-year cancer survivor. Let's listen to her journey.
Hi, thanks for inviting me in to share my journey with colon rectal cancer. Like she said, I was diagnosed at age 42. I wasn't hadn't had a colonostomy, but I felt very, very, very minor symptoms, and I'm not going to even say they were symptoms. It's like a stomach ache that you felt when your cycle was about to start, but it seemed like it lasted longer than normal. I had a lot of gastric noises that I had never had before, so I was listening to my body. I went to my internal medicine doctor, and he diagnosed me as having gastritis. Well, I took some medicine, and didn't get better. So maybe a month after seeing my internal medicine doctor, I actually saw blood in my stool. Not a lot, uh, but I had a lot of friends that were doctors, and I called Dr. Titus Duncan and asked him, was that supposed to be there? And he said, absolutely not. So he told me about Dr. Gary Richter, my best friend. But anyway, um, I got scheduled for a colonostomy, and lo and behold, there was a cancer. And I was diagnosed in 1996, and I had a metastasis in 1998. But my throughout my journey, and even now, I basically went on a plant-based diet, reduced my sugar intake a lot, um, was hospitalized a lot because I was had some issues after my surgery. I had maybe 5 blockages that I had to go back in for more surgery, more surgery, more surgery, but got better. 2 years of chemotherapy, and when completed my second year of chemotherapy in 1998, I had a stomach ache. So I was thinking that something was wrong. I went in for a overview of everything that was happening, and they says nothing was going on in your colon, but there's a spot on your lung. So I immediately was sent to Atlanta Medical, where they performed surgery, removed the right lower lobe of my lung, another year of chemotherapy, and has been cancer free since 1998. But back to the colon, I have a colonostomy once a year, have since for the last 23 years, which I'm so happy that I do because I have polyps, and Dr. Richter is able to remove them through the colonostomy. So, my suggestion and the way I talk to people about colorectal cancer is please get screened. Colonostomy, I think, is the best way to go. The meat, try and reduce it as much as possible. Listen to your body. When things change, and I know as we get older, aches and pains occur that you haven't had before, but if you really listen to your body, you know that something's going on different inside your stomach, and if it persists over a week or 2 weeks, have yourself checked for colorectal cancer, because um, at 42, that was the last thing I was thinking I was going to be diagnosed with. But like I said, my journey has been successful. I continue to get my screenings every year. I will continue to get my screenings every year. I exercise. I eat proper. I try and get lots of rest. Um, I'm very active with my grandkids, and I just want the public to know that screening for colon cancer in our race is very, very, very important.
Thank you, Marshall, for sharing with us your journey. I have several questions now for the panelists. I'd like to start first with Dr. Gary Richter. Dr. Richter, what are the stages and prognosis for colorectal cancer?
Well, you know, let's look at it from this perspective. You can do a colonoscopy and remove a polyp. If the polyp has a cancer in it and it doesn't infiltrate into the wall of your colon, you're cured with just a polypectomy. But then as you progress, if you have a cancer, then it has to progress through the wall, into the wall of the colon, into adjacent lymph nodes, and into distant areas. So when you have a cancer that really is contained to primarily to the colon, the prognosis in that group of patients. So, we usually, I'm not going to bore you with all of the different tools that we use. But if you have the tumor and it goes to the nodes, then that changes your prognosis. Then you end up having to have chemotherapy and make sure that there's no additional you follow up. Those patients are not cured simply with surgery. If the cancer goes to the wall but doesn't go outside of the wall, you theoretically can be cured with surgery. Sometimes the cancer may not have any nodes, but it can attach to another structure, and that can be resected as long as the cancer is not outside of the wall. So when they resect the colon, they resect the section of colon, the lymph nodes, and then preoperatively. So if I see a patient with cancer, I tell them it looks like you might have cancer. We're going to do a CT scan, chest, abdomen. We do blood tests to see if the cancer is outside. So you monitor the CEA, and you monitor their CT scans. Now, once they involve the nodes, then the prognosis starts to be reduced a little bit, and those patients have to have adjuvant therapy with chemotherapy in the majority of times. Then you have distant metastasis, and like Marshall was saying, what she didn't say is that when she in the 90s, people were saying, well, there's nothing we can do. You got cancer, you got colon cancers in your liver, in your lungs. They don't want to do anything. But she persisted and had it resected. That is really, that's, when you have a distant organ, that's stage 4 almost. When you have liver and normally it goes to the liver, but when you have liver and lung, you have to assume that it's probably in the liver. So, that's just absolutely amazing. But that's the way we do it. We look at the tumor, the nodes, and whether it goes to distant organs. That's what we call metastasis. And that's how we correlate outcomes, mortality, morbidity, likelihoods. Yes.
You mentioned several things that can not prevent, but assist in decreasing your chances of colorectal cancer. I imagine that having stage 4 colon cancer, is that necessarily a bad prognosis, or can one survive from stage 4 colorectal cancer?
Well, it depends on your will to live. Most people get the diagnosis of cancer, and I have to say, Marshall was just she was strong. I mean, she didn't let. I mean, it's very easy to become depressed. Once you get depressed and you have cancer, the outcomes are not going to be good. I mean, you can, that's just the way it is. But nowadays there's so many new modalities. What I usually tell my patients is sometimes if somebody says, "Well, you go to a local person, they're looking at you." If you have cancer, my patients, I talk to them about it, and it's a little different I'm going to suggest that you go to either MD Anderson or Sloan, because those are the centers of excellence. And they are going to take the step. Now, one of my colleagues his wife was diagnosed with colon cancer. And she was told that there was nothing that they could do. So I suggested you go to MD Anderson. The good thing about them, they're going to sit down and talk with you about what options are available. If those options can be available in your city, they will identify the people that you go to. And that's my approach, because if you want to live, you're not thinking about, preparing your will. You want to live, and you want to give every opportunity to do that. There's so many new chemotherapeutic options. There's so many. They have. There's so many changes that have happened that I think you have to put yourself in the best position. And I have to tell you, you have to make the right decisions, and sometimes you have to have a significant other that helps you to make that decision. When my patients come in, it's weird because you know, uh, a patient will come in, they have a problem, especially if it's a man. And I will tell them this, and they laugh at me every time I say it. I ask them if they're married, and they'll say, "Why you ask me that, doc?" I said, "Because if you're married and you'll take your wife when you see the doctor, because if you're not asking the correct questions, your wife will answer the questions. You have to have an advocate when you go in and see the doctor and you have a condition like that." And but I do use the Center of Excellence for pancreatic cancer, for example. I was using Hopkins a lot because they had the largest numbers as far as cancer. But Emory's catching. It was catching up.
A quick follow-up to that, what you have stated. I want to ask Marshall this. How important is the support system? Do you feel that you had a great support system? And what is the ideal care management team? I cannot hear. Marshall, can you unmute yourself? I can't hear you. Okay, let me ask the next
Okay.
question.
Can you hear me now?
Yes, thank you.
Sorry. Okay. I had a great support system. I had my doctors, my family, the community. Um, that's very important because they didn't let me get depressed. I was a fighter, like Dr. Ricker said. I wasn't settling for I have cancer and go sit in a corner. I fought. I was proactive. I did things. I did everything the doctors asked me to do, and I did other things that I researched for myself to do to stay strong during the chemo and the radiation, and just keeping my mental outlook positive. I was like, I'm going to beat this. I know I will. But anyway, like Dr. Richter said, frame of mind is 99% of the fight.
I agree with that. In most circumstances and most challenges,
Right.
the frame of mind and having the mental support. I have another question for. I have a question for Casey. Do you measure? Do you measure the waist at your belly button?
Yes, to measure your visceral fat, you would measure it right around your belly button. And Marcel, I wanted to say you have such a beautiful story. That was great. Thank you for sharing.
Thank you.
And another question for Casey is, what exactly is the plant-based diet? And is there any flexibility with it? Because we hear and we've heard from Dr. Richter as well as Marshall that they eliminated red meat. Do you have other suggestions for individuals that do not cook often? I've oftentimes heard people say, well, I can't go on that plant based diet because I don't cook. What are your recommendations? And can you still have occasionally a chicken, a fried chicken leg, a piece of fried chicken, Popeye's chicken?
That is a great question. And I always say it would be hard for me to live in a world with I couldn't have chicken every now and again. So most there's different versions of a plant-based diet. Some people choose to go completely vegan, which means no meat at all, no dairy, no eggs, no cheese. There is vegetarian, where some people will still include eggs and dairy. That's called ovo-lacto vegetarian into their diet. And then there's just being mostly plant based, which is what I consider for myself, where I don't eat meat at every single meal. I manage my portion sizes for meat. I make sure most of the things that I'm eating is coming from whole food plant based, which is a key term, is the whole food plant based, because has anyone seen like the Impossible Burgers and the Beyond Meats and all of those things? Well, there's still a processed food, right? Because they're not necessarily coming from natural sources. And if you turn around on the back, the sodium content is incredibly high. So if you want to keep your life super simple and easy, Bird's Eye now makes a really easy to heat up power blend. You throw in the microwave for 1 minute. It's full of grains, edamame, even has like some corn and some a low sodium Southwest sauce on it. There's all these pre-packaged fresh vegetables in the produce section. I love to take a bag salad and just easily open it up and have it for lunch. It's so easy to incorporate plant-based food items. It actually takes less time than cooking and making meat. And if you're just very confused, take a bag of Brussels sprouts, throw it in your air fryer with a little bit of Mrs. Dash, and you've got like a 5-10 minute delicious meal right there too.
Oh, wonderful. That's an idea. I love my air fryer. I have another question for Michelle. Michelle, do you have any lasting complications post your surgeries, radiation therapy, and chemo? How has it changed your lifestyle?
Well, after chemo, I was having a slight problem with my eyes before chemo. After chemo, I became visually impaired. But a lot of people don't know that because I still do everything I normally do except drive, which was a lifestyle change, which was pretty dramatic. But as far as the other things with the chemo and the radiation, I'm having some problems now. 23 years later, because I have some surgical changes that are occurring, and Dr. Richter has me going in to see a colorectal surgeon in a couple of weeks that I hope we can fix it. And it's things to do with my sphincter. Um, Other than that, uh, I'm going to have hip replacement. I found out today, and it's maybe because of the radiation that I got back there. Um, can't say for sure, but he says he's 80% sure that what happened. That's what happened. Other than that, I'm good.
Michelle, you have such a positive attitude. You
Yeah.
have such a great spirit. Thank you so much for sharing your journey. Thank you.
Thank you guys for having me.
It has been wonderful. I want to also add a question for Dr. Richter that has appeared on the screen. What role does red meat play in a diagnosis of colorectal cancer?
Well, I look at it this way. First of all, uh, I'll give you a disclaimer. I don't eat any meat or anything. So red meat is a carcinogen. I mean, it causes, it's associated with different cancers. It has a lot of fat, and the ultra processed food is the same thing. The American, the World Health Organization has come out and put it as a risk factor for colon cancer. So I advise my patients to limit it. Now, if you go to China, for example, they do eat red meat. The problem is we don't eat as much plants. And I have a saying in my office. I tell everybody after colonoscopy, 5 to stay alive, 5 servings of different fresh fruits or vegetables per day. Now there's an article in circulation which says that if you eat 5 different fresh fruits or vegetables, you live longer. If you look at 2 groups, they reduce the overall risk of cancer, especially colon cancer, and their cardiovascular risks are reduced. So I consider red meat and processed food a risk factor. Part of it is because we don't eat as much red meat. I mean, vegetables. I mean, because I know in China I noticed they do eat red meat, but they have a lot of vegetables on their plate. And I usually tell patients their plate should be colorful. I mean, they should have a lot of plants on their plate. So that's what I think. And then too, I forgot to mention that if your vitamin D is very important, it is associated. There's an article out that talks about the reduction in and improved outcomes of polyps and colon cancer. So you should make sure your vitamin D level is normal. Okay, if it hasn't been checked, make sure it's normal as well. But red meat I feel, is a carcinogen. I'd be interested to see what Casey would like to say about that.
Casey, do you want to add to that regarding?
Very much so. I'll have tools like this in my office as well, and I'll have like a 3-ounce piece of chicken versus a 3-ounce piece of beef, and then I'll have like the corresponding fat tubes that go with it. And when you're looking at the difference, when it comes to chicken, it might have this much fat. When it comes to beef, it's going to have at least a 2 full, and that's the leanest type of beef that you can have. So say my palm-sized portion of chicken, my palm-sized portion of beef, I just added 200 calories because I chose beef. Because it has so much fat, it's sitting in your gut longer, taking much more time to digest, which can cause its own oxidative stress there. And then in America, we don't treat our animals the best. We're trying to have as much turnover, getting as much profit as possible. And so the additive of hormones and antibiotics and just the overall food that we're feeding to our animals is just not good for us to ingest, as well as definitely not good for them to ingest either.
Thank you very much. Again, I want to thank our panelists, Dr. Gary, Marshall, and Casey. I would like to leave you with a resource guide that will soon be on the screen. But please note that within this resource guide, we have listed, it's so important, as you've heard from Dr. Richter, screening is important. Therefore, we have listed for you Dr. Richter's practice, which is consultative gastroenterology. We have a practice from Dr. Haywood, which is North. And then we have south of the airport, Dr. Ralph Lyons. So if you have your cameras, just take a picture of the screen. We've also listed Casey as a nutritionist for reference and some cancer-related organizations. Lastly, I would like to say thank you for our audience participants. You have truly shown an effort and the significance of engaging, education, and empowerment. This is how we will impact health disparities and people of color. It is on behalf of Camellia Rose that we are reaching out to educate the community, to engage everyone, as well as empower you. Thank you.
Thank you.
Thank you.
Again, to our panelists
Yes.
and to our phenomenal moderator and to you, our guest, thank you so much for joining the webinar this evening. Have a great evening.